Hello, everyone. Welcome to our webinar today with Students for Liberty South Asia and the Center for Civil Studies in Delhi, Civil Society in Delhi. My name is Fred Roeder. I have the honor to moderate today a very international panel. While I'm in London, we have panelists today from India and the United States. So we literally cover many time zones from very early in the morning to fairly late in the evening. And what we all have in common these days is that we're facing a global pandemic, COVID-19. Probably it's pretty hard not to know of that. And what we see is a very unique situation where nearly every country in the world, every nation, every economy faces the fear and threat of a novel virus. And there are very different public policy responses to this. We can be very sure that this year we're going to face a global recession, given the inactivity of our economy in the last couple of months and weeks, and probably moving forward. This is something we're going to discuss today, and also trying to figure out what are good policies for countries in order to, at the same time, fight the coronavirus, protect patients and people, and also how to make sure that the unintended consequences of these policies are not going to hurt us more than what they actually gain us in terms of public health. For this, we have our international panel. We have Bhuvana Anand from the Center for Civil Society in Delhi, India, which is a public policy think tank, one of the leading ones in India. And their focus has been on economic freedom, especially for the economic freedom and prosperity for the poorest, how to elevate poor people into middle class and prosperity. And Bhuvana especially leads the work on public finance, regulation, and new public management related to better governance. So we're going to be very interested in what you can tell us about that in the context of COVID-19, and how we can, especially how India can create a framework that allows to be resilient towards this crisis and make sure that economic growth can be reinstated. Then from very early in the morning for Jeffrey Singer, a medical doctor from Arizona. He's a general surgeon for more than 35 years and also extremely involved in different civil society and professional organizations. Jeffrey is a fellow at the American College of Surgeons. He's a senior fellow at the Cato Institute in Washington, DC, focusing there on health policy studies. And Jeffrey has authored several studies focusing on reforming healthcare system in the United States, drug policy reform, looking at drug prohibition, but also in general regulatory reforms. He's also a member of the board of advisors of the board of the American Council on Science and Health, and a visiting fellow of the Goldwater Institute in Phoenix, Arizona, his home state. It's probably also going to be interesting because the Goldwater Institute is one of the leading think tanks in the United States talking about earlier access to experimental medicine. So very much looking forward to also talk about that topic. And then our third panelist is Raymond March, who's an assistant professor of economics at North Dakota State University. And so it's also pretty early for you, Raymond. And he's also a fellow at the Center of Study of Public Choice and Private Enterprise, research fellow at the Independent Institute, where he runs a project called FDAReview.org. Maybe during this conversation today, you can also tell us a bit about that project and how that might be tied into the current public health crisis. I'm a health economist myself, as you probably can hear from originally from Germany. It has been never easier to get published on very fringe regulatory issues in pharmaceutical research, vaccines. For the last couple of years, my commentary and research was hibernating because no one was really interested in reading any of this. And suddenly we have 7.8 billion humans interested in such fringe issues. Therefore, I'm really excited to meet all of you. How we're going to do this is that we first have about 5 minutes from each panelist to tell us a bit about her or his views on the current crisis and their specific viewpoint on what good public policy is with respect to COVID-19. And then we'll have a Q&A. I will ask the first couple of questions to our panelists, and then we would love to open this up to all of you listeners. You can chat with us on YouTube Live, and we will collect some of your questions and discuss them among the panelists. So without any further ado, Bhavana, we would love to hear what is the situation currently in India, especially looking at public policy. What is the government's reaction to all of this? Maybe also for just international listeners and viewers, how many cases do you have in India? Is it already a huge burden for your health system? And what's happening right now?
Thank you, Fred, and great to be here. How many cases does India have right now? There is no good answer for it. We have the formal official numbers, but we don't know the validity of these numbers. Part of the problem is we just haven't tested enough people. As of, I think, yesterday, we had barely done maybe about 2.5 million tests, which is insufficient to be able to, for the kind of scale. Remember, India is 1.3 billion people, for the kind of scale that we have. I want to focus sort of my remarks largely on the institutional framework that has brought us here, and perhaps that can shed some light on where do we go from here. In particular, I mean, some of us are health economists, so think about this from the point of view of incentives or from the point of view of the role of the government. And this panel in particular is talking about regulation. So first, I mean, the simple summary of it all is what should the role of the government be, right? Pandemic or no pandemic, broadly in the public health spectrum. One big thing that has happened over the last few years, not just in India, but around the world, is this emphasis on healthcare versus public health. And the emphasis, where the emphasis falls means we make very different types of choices. And the same has been in India as well. There has been a lot of sort of primus put on provisioning of healthcare. So whether it is setting up government infrastructure in healthcare, hospitals, labs, clinics, or whether it is on government procurement and monopoly, but less so on the institutional framework that would bring private players to the fold. That we have a thriving private healthcare market is purely, sort of a supply response, right? Or to a large country which is also growing. With the story of COVID-19, I don't think India reacted badly. I think it was delayed by a couple of weeks in enforcing the kinds of measures it did. Some measures were reasonable given the amount of information we had at the time, but many of the measures weren't. I want to walk through some of the measures that I think were more ill-conceived compared to others. In particular, the story of lockdown, right? What does it mean for us to have enforced this kind of a strong lockdown, where the government said, listen, what seems to work is social distancing, but people aren't taking this seriously, and so we're going to come in and enforce the lockdown. To my view, for a country like India, with the kinds of problems, particularly with literacy, information, as well as density, we didn't have much of an option from lockdown. That being said, what do you do during lockdown? You prepare, right? You get ready for de-lockdown, because that's the goal. The goal is not to be shut off in our houses, but to kickstart the economy again and get critical healthcare prepared. What did we do there? That story is less sort of exciting. First, the Indian Council of Medical Research is sort of has been assigned regulatory powers in this time towards the testing infrastructure. For this, first government stepped in and said, we're going to be the monopoly providers, which meant all of the labs that were accredited were government labs. For the first 3 weeks of being in crisis, or 2.5, 3 weeks of being in crisis, we only accredited government labs. Then we slowly started to accredit private labs. Even though we know that the Shruti Rajgopalan and Alex Tabarrok at Mercatus Center at GMU have a great paper on the state capacity in healthcare in India. And it gives you a reasonable sense of what the numbers look like, and they're appalling compared to the rest of the world. But we took forever to co-opt the thriving private sector into the question of testing. Healthcare is, of course, subsequent. We first need to know where the sort of hotspots are, what's going on, what are incidences, what is the prevalence, what is asymptomatic versus symptomatic, all of the data points that we need to be able to make good decisions further down. So that was step one, where we made a mistake. We brought the private sector in too late. Second is that we didn't ask the question of how do incentives play out, right? For example, the government has I've spent the last few days speaking to a lot of the large lab providers in India. And they pointed out that the Indian government has basically priced them out of the market on the disposable units of testing, so reagents and things like that, right? So where a private company would have paid $10 or $15 a unit, government has gone in and said we'll pay $50 a unit. For a country like India, this is huge. This is cornering a market and such disservice to public, to the exchequer, right? How are we going to direct that? So this is mistake, I think, number 2. Mistake number 3 is also sort of risk aversion. The idea that the lockdown will somehow control the virus. And what we know from viruses is that's not how it works. What the lockdown gives you is time to prepare and line up your ducks so that eventually you're able to emerge. The fourth thing that it went about doing incorrectly is the process of approvals, or the stringency and the protocols that it actually applied to private labs for approvals, right? The Indian government, in a departure from accreditation bodies around the world, insisted on 100% specificity and 100% sensitivity of the tests. This is absurd. Most countries, including the US FDA, have settled somewhere between 98 and sort of 99.5% or so, right? Asking for 100% indicates this kind of risk aversion, which we just can't afford at this point. We don't know enough about. I think just prior to the start of the panel, Jeff was mentioning some of this as well. So this is the fourth way that it, sort of has not done right by the public, I think. The fifth is international tariff barriers, right? I think the Taxpayers Alliance in the US, if I'm not mistaken, released this very interesting report last year on the trade barrier index. Unsurprisingly, India and China were at the bottom of the index, both on tariff measures, non-tariff measures, and sort of other kind of restrictions on borders. It turns out that Indian tariff structure on medical, biomedical, and allied are atrocious compared to the rest of the world. But more importantly, in this time, we have not managed to relax them. So there are goods that are languishing at the ports, and combined with the lockdown and not having personnel, you've sort of tied yourself or in a bind, right? So it's a fifth way that we've, I think, made a mistake. And the sixth and the seventh, I think, are broader, longer term mistakes that have come back to sort of haunt us now. In particular, our entire regulatory infrastructure around lab accreditation and regulation. India passed something called the Clinical Establishment Act a bunch of years ago, but most state governments in India have not implemented the act. And so the regulatory framework is both very open, but at the same time amenable to enormous amount of play. Second is that what do we want for sort of customers? What are we protecting them against? One, we want contracts to be enforced. Two, we want a tort system that works. And three, barring 1 and 2 sort of not working perfectly, you want a consumer protection framework. Now, we fail on all 3 of these, right? And this is something that the World Bank has noticed time and time again on the ease of doing business index for India. Separately, on hospital clearances, one of the things that Tabarok and Rajgopalan point out, that we just don't have enough hospitals and hospital beds. Here is an interesting factoid. The way the government regulates hospitals, or in order to set up new hospitals, you also have to, among other clearances, get environmental clearances. The environmental clearances are tied to a per bed ratio rather than an emissions, either pre-thinking on emissions and then actual emissions ratio, which would be the right way to play the sort of the incentive structure, right? Again, we messed up, and now we've got the situation where you've got high emissions, but you've also got fewer hospital beds. Lastly, on personnel. Ultimately, the entire healthcare industry is about people. What have we done on certification? For example, doctors, right? We were running a bit of a guild system here in India. More recently, we've come up with the National Medical Council Act, which should have provided us some relief. But it takes a long time to correct things that have been systematically sort of damaged. So, for example, the Medical Council of India previously enacted enormous barriers to entering the medical profession, which if you were rich, you could get in, but if you were qualified and had capability, you would struggle, right? So what did you do there? And the last thing is, there is an art of government, right? And there is a science of government. What does it mean to do government right? We know this from new public management literature, that what you want is not necessarily to provide, but to get your systems such that you are able to do financing and let the private sector do what it does. India has not managed to get, sort of do sound contracting, do sound procurement, understand and bring private sector players and understand how the incentives of the system work. Understand that price ceilings are not the right way to go, but what you want instead is for for the emphasis to be towards lowering prices in the long term, whether for goods or for services, be drugs, hospitalization, etc.
Right.
Lastly,
I think this is all extremely interesting, Bhavana. I think just like I think we're pretty going in a deep dive of shortcomings of public management in India in general, and I think this could continue for a long time. But thank you for this intro and giving us all some perspective on what's happening in the second most populous country in the world right now, maybe even the most populous one. So definitely also really interesting, maybe we can continue talking about this a bit later, is the access and affordability and accessibility to treatments, tests, vaccines, cures. And India has definitely both internal and external trade barriers that make pharmaceuticals and testing equipment often much, much more expensive than they actually would have to be. And that's interesting because it's combined with a policy that hurts the private sector by taking intellectual property rights away, but then the government makes things artificially more expensive through wholesale markups and trade barriers and sales taxes. Jeffrey, the United States was one of the first countries that imposed travel bans, at least one of the first countries in the Western Hemisphere, definitely early on to China, also to the European Union, Schengen, and later on the UK as well, and Switzerland. Nevertheless, right now, if we look at numbers, it looks that the United States is the most affected country by COVID-19. Maybe it's just because of very rigorous testing, or it's actually because the US might also not have this under control. Maybe you can give us some thoughts on what currently the situation in the United States is and what public policies are trying to contain this problem.
Sure, thank you. First, I'd like to stipulate, since this is a Students for Liberty conference, many commentators have said, so now how do libertarians feel? Or have said things like there are no libertarians in pandemics. Well, in fact, this libertarian, and to my knowledge, all libertarians except anarchists, believe that this is one of the legitimate functions of government. The government's job is when you have a pandemic, it's analogous to being invaded by a foreign invader. And the function of the government is to protect our rights, to protect us from foreign invaders. And when a person is infected by a virus or bacterium that could then infect other people and threaten their lives, the government's job is to step in. I think as libertarians, we have a tendency to have a predisposition towards wanting decentralized solutions whenever possible, based upon local knowledge, and one size does not fit all. That's our general predisposition. And listening to Bhavana, it's interesting that there are a lot of similarities between India and the United States, and there are a lot of differences. So in the United States, what happened was the government failed on multiple levels. So first, it failed by actually not disseminating accurate information to its citizens. First, we were being told by the people in the CDC, the Centers for Disease Control and Prevention, that this was something minor, analogous to the flu. Don't worry about it. Then, as late February approached, we were told the opposite. We were originally told, don't wear face masks. They don't do you any good. But there was always this kind of confusing thing about that, because they say face masks don't work, so don't wear them. And besides, the healthcare workers need them. And you're starting to think, well, wait a minute, if they don't work, why do they need them? But in any case, they were telling us that, and now they're telling us wear face masks whenever possible. So the government failed on an information level. Now, on a regulatory level, it's interesting how many similarities exist in the United States with India. Our Food and Drug Administration, FDA, has very complicated, lengthy approval processes when it comes to drugs and tests. So when the genome to the virus was isolated by the Chinese and delivered to the World Health Organization, in several countries, commercial tests became rapidly available. South Korea learned from its mistakes of the MERS pandemic that really harmed them in 2015, where they had a monopolistic centralized control as exists in India today. So they actually passed legislation saying in the event of an emergency, all private sector commercial labs are hereby permitted to just develop tests, obviously keep our agency informed in the loop, but get them out there, do what you have to do. That didn't happen in the United States. So at first, the Centers for Disease Control got the genome, they developed a test, it got what's called an emergency use authorization from the FDA. Emergency use authorization basically means because it's an emergency, we're going to permit you to use it, but we don't officially approve it. But it satisfied enough rudimentary concerns that we're okay with you using it. And then basically sent out a message to all other public health labs in the United States that were interested in developing their own tests, because to develop PCR tests once you have the genome is not very complicated. Most academic and commercial labs could do it very readily. The message was anything you develop has to get approved by us, the FDA said, and we also want your test to be checked by the CDC and compared to their tests before we will consider it. Well, of course, this sent a message. Number one, it's not worth your while to do this because it's a regulatory obstacle. Number two, the message sent out is basically the CDC has got this. This is so don't bother. The CDC is on the case. And of course, we learned in late February when the few labs that the CDC got the tests out to, that the CDC tests were flawed. I like to liken this to, this is the kind of mentality that I would have expected in East Germany. And the test that the CDC developed was the Trabant. And it's very sad and ironic coming from the United States, which is supposed to be, the beacon of liberty and free markets. So we had this monopolistic government-run command and control system. Finally, I don't want to get into too much detail, but eventually by mid-March, the CDC took a page out of the book from Korea and said, any state, we have, of course, a decentralized system in that, a federal system. Any state could could permit any tests they want within their state borders. We're basically devolving that authority to the states. And that helped get a lot of tests out there. So now there's been a lot of testing done, including antibody tests. Some states are way ahead on antibody tests, like in California, and those tests haven't necessarily been approved, but the FDA only approved so far one antibody test. In California, Stanford University reported yesterday the results of a study done on 3,300 residents in the Silicon Valley using an antibody test, where they found that actually the infection rate is about between 50 and 85 times greater than the case report rate based upon their antibody test. So it's, the good part about this is we're decentralizing now. That just deals with the testing. On the state level, we have obstacles to the free flow of healthcare because of medical licensing laws, not unlike India. And of course, those laws were put into effect 100 years ago by organized medicine seeking to restrict competition and new entrants into the field. So we have a guild system as well. We have a cartel. Several states have waived the licensing requirements because of the emergency to allow doctors and nurses and other healthcare professionals to come to their state and help. But that's just temporary. I, of course, believe that should be permanent. My state of Arizona 2 years ago passed a law that basically says any person in any licensed field, from medicine to law to carpentry, who moves to Arizona and has a license in good standing in another state will be granted the license in Arizona. That's a good step in the right direction, and 2 other states have done the same. However, you still have to live in Arizona for that to work. And then telemedicine has become extremely valuable in this situation. Of course, it's valuable even when we don't have an emergency. And we have obstacles to that as well because of licensing laws. So for example, each state permits telemedicine, but only by practitioners licensed within the state. So I live in Arizona. If I had some very complicated esoteric illness that a professor at UCLA Medical Center is the renowned specialist of, and I want to go travel there and be seen by that doctor, that's perfectly okay. Supposing, though, 3 months later, I need to have a follow-up appointment, which is about a 10-minute visit. I can't do that by telemedicine because that doctor is not licensed in my state of Arizona. I have to get on a plane and fly to California again for a 15-minute visit. We should, our Constitution gives the federal government the authority to break down trade barriers between the states. We're supposed to be a 50-state free trade zone. And so that legitimately, the Congress has the right to regulate commerce between the states. And this is a trade barrier because while I could purchase a product manufactured by a company licensed in the state of California, I can't purchase a service by a healthcare practitioner licensed in the state of California. So we should have a national law that says that the locus of care is the state in which the practitioner is licensed, not the state in which the consumer resides. And that will be completely legitimate and solve the problem. But ideally, of course, we shouldn't have licensing laws at all. We should just have private certification. So it's interesting that there's similarities and differences between India and the United States. I think it's also important, just like within certain states in the United States, there are like New York and New Jersey are devastated by this, but then other areas like even California, with a population of 40 million people, has about 1,000 deaths, and now we're learning probably has a great much lower infection fatality rate than originally thought. So one size does not fit all. I think public health measures should be tailored to the region, taking demographic and other geographic concerns into consideration, and of course should be very flexible and able to change very quickly depending on changes on the ground, and regulations stand in the way of that.
Thank you, Jeffrey. And it's really sad to see that it took weeks to change the approval process for testing in the United States. I actually did some research on the testing processes in the European Union, and it turns out that right now COVID-19 tests are seen as non-dangerous tests. So manufacturers can just produce new tests and bring them on the market, and they basically self-certify them. Therefore, especially Germany, with a very strong medical devices industry, was able, I think the first test in Germany was developed in mid-January, and now there are dozens of manufacturers, which helped, of course, to get these tests also quickly to private laboratories around Germany and help to early discover cases and early treat them and contain them. Whereas, for instance, the United Kingdom, where I'm based at, is still struggling with testing more than 10,000 people a day, which is basically they cannot even test their own healthcare professionals to figure out if they should still work in non-COVID-19 departments. But so these are often national shortcomings, regulatory shortcomings. Ray, obviously you also have the chance to talk about things in the United States, but maybe you can also have a bit of, if you want, a global look. Where was the information stuck? Were there also communication delays from the source of COVID-19? Were there international bodies that did not what they were supposed to do? That, if you want, maybe you can also talk a bit maybe about the WHO if you feel comfortable.
Yeah, I think the great place to start is sort of where we are globally with terms of this pandemic. So as of this morning, information from Johns Hopkins University says there's roughly about 2.2 million cases across the globe, about 155,000 deaths. The United States, as we had mentioned, right, is sort of bearing the brunt of the COVID-19 epidemic at this point. And what I've been doing in my research, in addition to looking at sort of international bodies and how they're transferring information or not transferring information based on various regulations, is trying to ask, so how are countries dealing with this? And we've heard a little bit how the United States has similarities and differences between India. I think by and large, most countries have been approaching this by saying, we need to crack down. Right? We need lockdowns. We need to put restraints on the economy. We have to restrict individual behavior. And all of this is really an attempt at what's in the United States is called flattening the curve. I think that's become more of a global term at this point. That's the idea that we're well beyond the stage, if you will, that we can actually prevent the virus from spreading. What we have to do instead is sort of spread out, at least over a longer period of time, who is getting the virus and who's going to need access to healthcare, ventilators, and things like that. And the idea is we won't overwhelm the healthcare system by having so many cases at once or having a large outbreak. And by and large, I'd have to make 2 points on this. One of which is what a lot of people don't necessarily recognize from just hearing the term flatten the curve is what that does is it prolongs the epidemic, or it prolongs the pandemic. Right now, the United States, even though, as Dr. Singer has just pointed out, right, we're seeing antibody tests come back that indicate it's actually a lot more widespread than we think, and possibly the fatality rates are a lot lower than we originally estimated. I've seen academic articles saying we need to have a shutdown until 2022. Right, yeah, and that's going to, of course, shut down the economy for at least another year, which has its own consequences on well-being and individual satisfaction. Not to mention, it also hurts the healthcare system, right? To have high unemployment rates and then people coming in for medical treatment. A lot of those are being ignored, unfortunately. But what I really have been focusing on, and at least since the epidemic has broken out, is when you hear the term flatten the curve, that's all based on the assumption that healthcare capacity is fixed. But there's only so many ventilators, there's only so many doctors, right? And if we overwhelm the system, people will get sick and they won't get adequate care, and that's going to make the outbreak that much more severe, or that much more worse. I've never understood the assumption of why healthcare is fixed. I really haven't. And I think when we look into the information a little bit more and we say, well, there's only so many ventilators, there's only so much hospital space, only so many doctors, only so many masks or tests available. I mean, that's not how a market works. When you have a market and you run out of supplies, people who supply those goods go and scramble up ideas and try to find ways to get more products to consumers or patients, which runs us into the problem of, okay, well, why aren't there more ventilators being produced, and why haven't tests become as accessible as we previously, or as we think they should be? And then we run into the problem like the previous two panelists have spoke about, right? Regulation doesn't let that happen. And that's sort of, I think, on a global scale, that's exactly the problem we're seeing. But what I've been focusing on is rather trying to make the case that, so we believe that getting rid of these regulations will help, if you will, treat more patients and make the pandemic less harmful, or at least get better access to healthcare to people that are suffering. And what I've been looking at instances of, okay, where do you see deregulation? And unfortunately, there are not that many cases available, but where do you see deregulation, and is the world getting better? Is the pandemic being better addressed through that? And where you do see examples of that, I think the answer is overwhelmingly yes, like unambiguously yes. So we had talked about South Korea. A lot of people don't trace back the history of the South Korea testing system. So about 4 days before you had the first reported positive case of COVID-19 in South Korea, there was a private company called Seegene. I might be pronouncing that incorrectly, and I'm sorry, but this is a company that anticipated, sorry, my own pronunciation, and this is a company that said, okay, cases are ramping up in China. We're neighbors of China. Eventually that's going to make its way into South Korea. People are going to need to have tests to figure out if they're sick with this illness. And they said, we've got to ramp up and make these tests. And that didn't come from any government order saying you have to start making tests or start looking into this. Is a company that anticipated an urgent need.
They just read the news.
Imagine that. Within 3 weeks, they had a testing kit ready. Keep in mind, within those 3 weeks, or that includes 10 days of getting formal approval process from the South Korean government. Within about 3 weeks of the first case coming in, they had tested over 230,000 people. And these were all efforts done by the private market, as Dr. Singer pointed out, right? That was allowed to happen. And South Korea, a lot of us forget, South Korea was at one point rivaling Italy as one of the countries that was most devastated by COVID-19. Now it's one of, I think, 2 countries where there are more reported recovery cases than new cases. And none of that would be possible if you don't have an adequate measure of how to figure out who is sick and who is not. And I think South Korea owes a significant amount of that to the private sector developing these easy to access tests. And we compare that to the American approach, just very briefly. We talked a little bit about that before. Dr. Singer had mentioned, right, the FDA really only allowed or had approved one kind of test. There's another line of regulation in there that says if you want it, going up until about 3 weeks ago, if you were a private laboratory, and most of the laboratories are private in the United States, and you wanted to test for COVID-19, you had to have a special certificate from both the FDA and the CDC, which are the major regulatory bodies. And that curtailed testing significantly. Thankfully, the FDA in the previous weeks has removed that barrier, saying, okay, now you can develop your own test, and if you want to test for COVID-19, go ahead. And so in those 2 weeks that private agencies have developed a test, this is a test run by Abbott Laboratories, an American company, where you can actually get a diagnosis of COVID-19, positive or negative, in 5 minutes. 2 weeks ago or 3 weeks ago, right, you couldn't test at all unless you're using the CDC's test. And you couldn't issue that test unless you had a specialty license. So I think those are just two very telling cases, right? Where if you do deregulate, you can see turnarounds and advancements in innovation and entrepreneurship, at least from a medical standpoint, very quickly. There are other examples, but I want to reserve some of the time for audience questions and some of the questions you have. But I think just very briefly, this panel is roughly about, right, how can deregulation help address the pandemic? And I say to really fully answer that question, you can start with looking at what are the regulations that have barriers, or how do regulations create barriers to this problem. Then you've also got to look at, okay, point to an instance of deregulation, what happened? And I have some examples, and I think they're very telling.
That's really interesting, Ray. Thank you so much. And looking at South Korea, a good friend of mine, an alumnus of Students for Liberty, is originally from Italy, and he works now in South Korea. And when the situation started in South Korea, I asked him, he's an expat there. So I asked him, is your company sending you back to Italy? Because it seems that South Korea gets a lot of these cases. And before that, it was just China who had the cases. And he was like, oh yeah, maybe I go back. And then suddenly the Italian cases were just like exploding. And he's like, I'm much better here in Seoul. This country has figured out how this works. And he still goes to the office every day. I mean, they didn't shut down public life. So Jeffrey, maybe looking at this, that actually one of the countries which was hit first and had 5-digit cases managed to contain this without shutting the economy down. And then we have examples of the state of Virginia, which has already said till like June or midsummer, everything is shut down. Maybe Jeffrey, you can maybe also compare Sweden and the United States. Why are different countries reacting so differently to this?
Well, I would like to get into that, but one other point I heard Ray mention about why is healthcare a fixed commodity, and in the United States we have something not unlike India that contributes to at least a portion of the healthcare system being fixed. We have 36 states have what is called certificate of need laws. So if you have a hospital and you decide you want to add on a wing or convert a part of your hospital that doesn't have hospital beds by adding hospital beds to deal with an emergency, you have to get permission from a committee that's usually made up of your competitors. And they have to decide if there's a need for more hospital beds, or in some states, even a CT scan machine or a PET scanner, and they decide if it's necessary. And the states that have that have had less flexibility in dealing with this problem. So to a certain extent, in those states, the healthcare system is fixed. It shouldn't be. Those certificate of need laws should be repealed. Now, to your other question, different states have different population densities, et cetera. So for example, in North Dakota, where Ray is, or in Wyoming, or even in Arizona, we're Western states, much less population density. People usually commute to work in cars by themselves as opposed to using mass transit. We're having a different experience here. Fortunately, yesterday, I think it was, the guidance was given by the federal government to basically encourage states to make their own decisions now about how rapidly they want to open up. And some states have already begun to do that just in the last 24 hours. Texas, Florida, hopefully my state very soon. I happen to personally, I'm very intrigued by the Swedish model, which to me just seems very rational, because as everyone has said on this panel, once we're let out of home arrest, we're just as vulnerable to the virus as we were before we were placed under home arrest. The virus is out there and it's going to infect people until we reach a state where enough people have developed immunity, either through vaccination or through getting the disease, that the virus is no longer a serious threat. And that's what some people call herd immunity. So we're already seeing instances where in some countries where they've reopened, they're having a second wave and a third wave. Sweden decided to have certain limited restrictions like crowd size. They closed the high schools and universities, but they kept primary schools open. And one or two other things. They've encouraged, and they targeted basically their policies at the most vulnerable population, which is the older people who have pre-existing vulnerabilities, and otherwise left it up to people to make their own decisions. And their fatality rate is somewhere in the middle of the European countries. But one point that the Swedish chief epidemiologist made the other day in an interview was that it's really not a good apples to apples comparison, because since they're not having a complete shutdown, they're not anticipating there'll be a second wave and a third wave, because they're just having, he used the analogy of, we're not shutting down, we're just pumping the brakes. So it would really be better to compare the outcomes, let's say 6 months from now, to the other countries who did shutdowns and have had second waves and maybe third waves. Another interesting difference, though, between India and the United States regards this, and this is similar to Sweden's experience. Most of the shutdowns in the United States occurred before the government started ordering shutdowns. South by Southwest canceled its convention. Then many other conventions and events were canceled. Then professional sports leagues decided to cancel their seasons, and Disneyland decided to close, et cetera, et cetera. And most businesses that could were already telling, including the Cato Institute where I work, were already telling their employees to work remotely and don't come into the building. And this is before any governmental top-down interventions took place. Now, apparently that's not the kind of thing we're seeing in India. And so that may have justified a more, a more centralized approach in India. But again, one size does not fit all. And there's every reason to believe that even if the governments in the United States said tomorrow that everything is open, we're not going to see people coming out and resuming normal activity until they're comfortable that it's safe. So Sweden is actually trusting a lot more to the intelligence of an informed public to make their own rational choices than the United States is. And we're a very informed public.
Who would have thought that Sweden is the role model for personal responsibility?
Yeah.
This is very interesting. I just, Pavana or Ray, if you want to comment on this as well, now is your chance. Otherwise, you would switch to a couple of the questions from the audience because they're also very good.
I'll just make a very brief comment because I think Dr. Singer addressed a lot of that. We talked just very briefly about Sweden trusting their public to make an informed decision. A lot of that comes back to what's the information they're getting. It's fundamentally, are they getting good information from the CDC? Are they getting lousy information? Are they getting mixed messages? So right now, as I had mentioned before, we're getting academic papers saying that antibody tests are actually very high. So it's probable there's a lot more cases of COVID-19 in the United States than we think. Then we're also seeing we have to keep shutting down and closing down schools until 2022. But one of the things that's been really concerning me about all of this is when you have voluntary measures like Dr. Singer brought up, where we're going to shut down this business or these schools, and that's determined at a local level, where you have local information to be able to determine this is going to be an appropriate policy for this long. Once you start getting up even to state and federal policy, I've never heard of a benchmark saying, okay, once the cases are at this, or once the death rate plummets to this, or we have this many confirmations of X, that's when we start rolling back. So some states are saying, yep, we're going to start rolling back now. Others are saying we're going to go until June to keep everything shut down. But there's really not, at least that I've heard, a governmental benchmark that says this is when we start reconsidering these policies. And until you have that, I think there's a lot of good reasons people wouldn't trust information or would sit in their homes even after barriers had been lifted, right, worried about what's actually happening.
Yeah, that's a good point. So inspired by Ronald Reagan, you can say there's nothing more permanent than a temporary lockdown. Pavana.
Let's step in for a second. Just speaking about, sort of context-specific responses, right? I couldn't agree more with the situations are so vastly different. Even in India, it's a fairly large country, both population-wise as well as geography size-wise, right? We've seen before the lockdown from the center, different states taking different types of measures, and some states coming out, sort of shining because of the kinds of decentralized governance that they were putting in place. But one of the things that stood out in this was that the states that had built the state capacity to execute beforehand, that had gotten their act together. So like, for example, in the case of South Korea and MERS, in the southern state of Kerala, they had dealt with the Nipah virus. And they had sort of put some practice into how do you think about a public health emergency. And they have done a reasonably good job of at least, sort of rallying the government infrastructure in order to be able to make sound decisions. So that's one part. And the second part of it is just the private sector response, right? So a simple in food aggregators, for example, just how quickly they responded with safety standards. And in the case of India, a couple of years ago, the Food Safety Administration had turned around and said, no, every single restaurant must be licensed by the government, and it's got to have this kind of safety requirement, which cannibalized private sector aggregator activity at setting up these kind of safety standards. So they just replaced and stopped all of their efforts. And before you know it, in this pandemic, all of the aggregators have come up saying that, this is the last that your delivery guy has sanitized his hand, or this is a kind of no-touch policy that we're putting up. We're doing contactless delivery, etc., etc., etc. So it's been also quite remarkable to look at what's happening. One last thought is on pooled testing, which is the new sort of hybrid way of responding as well, right? It's striking to me that this came up from a private university in Israel, right? And just for us to think about the university infrastructure as part of the private sector response mechanism, that we need to be able to unleash and open up to help us deal with these kinds of things.
Great, thank you. So I just want to make sure we also talk about some of the topics our very engaged audience is bringing up. And I see a huge pattern that many people want to talk about drug and vaccine pricing. So there's a couple of very similar questions. I'm trying to package them together. So we do have questions about price regulation and price ceilings. Is it finally time to add price regulation and price ceilings for equipment and medicines in the United States? That's one question. Then we have one on, shouldn't vaccines be free for COVID-19? So I think also something some NGOs are pushing heavily for. No one should benefit from this crisis. Then we have some questions about pricing transparency and the structure of healthcare pricing in the public sector of India. So that's not just pharmaceuticals, but healthcare pricing in general. So this is probably the biggest question. Should a pharmaceutical company benefit from bringing their vaccine or their medicine, their antivirals, for instance, to patients, or should this be for free, right? So this is like an ongoing debate. This is probably what many healthcare debates are about. I just read this morning that Gilead, a very innovative company from, I believe, the Bay Area, San Francisco, they produced a drug brought it to the market about 10 years ago, which was meant to fight hepatitis, was not very successful. Then they figured out it's fairly successful in dealing with Ebola cases, but they're more successful Ebola treatments. But this drug now is shown in a study which has just been published, very good effects to treat COVID-19. And I believe this drug could also only be used remdesivir due to some special permits, because it's so far not approved for the treatment of COVID-19 as some other drugs, for instance, hydrochlorine. And hopefully soon we'll see various vaccines for COVID-19 on the market. How this often works is that governments are creating a public-private partnership with pharmaceutical companies to basically say, once you have developed the vaccine, we're actually buying millions of these from you and bringing them to the population. But at the same time, there are voices who say we should totally nationalize all vaccine and pharmaceutical production and research. So where do we start? Who wants to go first? Jeffrey? Okay.
Yeah, as the non-economist on this panel, I'm going to then defer to the economists, but a couple of things. Number one, if you want to create a shortage, then put caps on the prices. I think we learned that back from the Roman Empire days even. Price controls don't work. So putting sort of price gouging laws into effect are a guaranteed way of making sure you're not going to get enough of the product out there. Now, from a libertarian perspective, I don't think, in the case of a public health emergency, I don't think it's unreasonable to have the government using ultimately the money of the taxpayers to purchase the vaccines to get everybody vaccinated as a public safety maneuver. And then when it comes to patents, that's an interesting thing, because even libertarians have arguments about whether there should be patent laws to begin with. I think it would be reasonable, personally, in an emergency like this, to suspend the patents and replace it with some sort of financial award for the development of the product, because a patent is basically a way of a person profiting from developing a new idea, and you don't want to discourage development of an idea. So if you replace it with an award that could also, reward the developer for the idea, at the same time not preventing others from getting in to make the product itself. I think that covered all of the areas that you brought up in your question, but now I'll sit back and let the economists comment.
I'll comment briefly on that, I guess, as the economist or the pharmaceutical economist. There's a lot of truth in what Dr. Singer just said, right? A reward is not the same thing as protection, which fundamentally that's what a patent is supposed to do. But even when you look at the US pharmaceutical market, it's only about 30% of drugs that come to market actually do make profit. And that's because of the amount of cost it takes to bring a drug actually to market. It's somewhere around 1.5 billion US dollars. So what I've been fundamentally looking at, and I think there is a lot of interesting debate as to whether the government should fund the vaccine, buy the vaccine and provide it at no cost to all of the consumers. What I'm more fundamentally worried about right now is that the US is about 2 years away from a vaccine. Maybe that's where that estimate of 2022 comes from, right? Because we're never going to get herd immunity. So maybe that's why the vaccine has become so important. But I think in the intermediate step, if we're not so much interested in the philosophical discussion, it's a question of how can you get the vaccine to the market quickest? Reward is part of that, but you've also got to remove barriers so that the innovation can come to place. So right now, I know the University of Pittsburgh has been doing a lot of promising work. Johnson & Johnson has clinical trials going out on about 800 Americans at this point. But even as the FDA can get it through as fast as possible, right, we're still at about 1.5 to 2 years away. So from a practical standpoint, I think most of the intermediate steps, unless we're going to resolve a big philosophical debate within economics, libertarianism, what have you, is trying to get those regulatory barriers out of the way. And I think other countries are having similar issues too.
Yeah, it's interesting, for instance, if you look at the first test developed by Roche Diagnostics, which was shipped to hospitals prior to the FDA approval. And there was like basically an agreement with the FDA that they can already ship it. And suddenly everything got fast-tracked, which usually takes 18 months. So suddenly if you have a public health emergency, these regulators are very quick in assessing if things are safe or not. I mean, which is maybe a good case for us to show things can move faster, and therefore also this regulatory cost go down, right? Because a lot of these $1.5 to $2 billion of bringing a drug to the market are regulatory compliance costs. And that's at the end of the day what then is being shown as, pharmaceuticals are so expensive. But a lot of this is actually because it's really expensive to comply and to run like for a decade trials, which are mandated, and patients and practitioners are not even allowed to access this earlier. Govana, probably the situation in India is also very different. India is a country heavily relying either on generic drug medicine or actually compulsory licensing, where they just take the patents from companies and say we manufacture it at our own price. Where do you see India and the entire debate on should the government have a bigger role in the pricing of drugs, or should the government have a smaller role because its big role actually leaves innovative drugs out of the market?
So I'm going to answer this question slightly differently. India is currently doing price control for testing. So the government already put price ceilings on what you could charge for a screening test or a serology test, what you could charge for a confirmatory test, the RT-PCR test, and what you can charge for home-based testing. So for each of these, they've put a band and they said no more than X. Now, this is interesting, right? When you speak to lab practitioners, they turn around and say, actually, today my cost to market is double what the government's price ceiling is. So as it is, I'm disincentivized. I know I will get to far less than the ceiling you have put in, but it will take me scale between now and 2 months hence for me to be able to issue these tests in the market. I need to be able to create the scale, right? So think about what we've ended up doing in India is we've simply said 4,500 is the price point. So there is no incentive for price discovery anymore. So which I think is enormously deterrent to what Ray said, right? The vaccine and the medicine story is still 2 years away, 3 years away potentially. Right now, what we have is pricing for testing. That's the thing we know, pricing for healthcare services as well. But if you've started to stop it right there, then you have no information, you have no ability to be able to feed into larger decision making. So that's one part of our approach. The second is our Supreme Court took a stand saying that testing has to be free for the poor, right? What does it mean for a test to be free? Nobody has been able to answer that question in the Indian government. So presumably what they mean is that there is no out-of-pocket spending for a patient, right? So I think that's how we should start phrasing these things. we don't mean that it doesn't cost anything. It means that somebody else picks up the tab, right? Now the question is, who picks up the tab and how? What does it mean to design a system where the government picks up the tab? And in this particular case, with virulent infections, I think there is a very strong case for the government to pick up the tab, if not universally, at least for a large section of the population in need. Why? Because of the externality story, as any economist would tell, right? But this requires a thoughtful design. This requires two things. One is to have some form of voucher system going, right? So that I am able to walk into any lab. And India is a fascinating example of the lab market. It's such an extraordinary responsive market for a poor country. We have more than 100,000 labs operational in India today. Only 1,049 of these are registered with the accreditation, the national accreditation body, right? A majority of these are standalone mom and pop laboratories. About 50% of the market are standalone mom and shop. How are you going to bring all of them in? One thing is to say we're going to shut all of them down. What you would have is 50% less labs, right? Or you could say you can't charge more than X, Y, and Z, which is partially what the Indian government does as well. And then the labs turn around and say, I'm going to divert my attention to what are called lifestyle diseases. So most of the lab chains in India today focus on lifestyle diseases, meaning obesity, diabetes, and the rest of those, instead of focusing their R&D on public health questions, right? This is what the price list has done. And the third part of it is that in order to be able to do strategic purchasing or to do vouchers, you need to know how to do public administration. How will you figure out what the negotiation stance is with private players? What does the tender document look like? Do the big guys rig the tender document? Do you have a front-end system of a database of beneficiaries? How do you target, et cetera, et cetera, et cetera, right? So I feel like this is a more complex question rather than a yes or no answer, and you should be phrasing it in those kinds of terms.
All right, so we have many more good questions, but only 3 minutes left. We have questions on the World Health Organization, whether their response was good. Questions to Jeffrey, how easy it is to actually mass manufacture vaccines. We have questions about flattening the curve, exponential versus linear growth. Won't be able to go into this, but I would ask each of you up to 3 policy points, 3 action items for policymakers, what they should do now in health policy to make us more resilient for this and the next pandemics. Ray, to start with you. And keep it please to a minute.
1 minute, 3 things to solve the global pandemic. Okay. I think the best one right now is to decrease regulatory barriers across nations for testing. The South Korean tests have made their way into Europe. That's been beneficial. They're still not in the United States. They're still not in South America. They're not in a variety of places. So decrease regulatory barriers for testing. I think remove regulatory obstacles to developing a vaccine. And the third one, this is probably one you won't hear again. I think that there has to be a lot more communication for off-label drug prescription. Now, there are barriers within the United States about transmitting information about when off-label, that's a drug that's approved for one use, used for another, like you had brought up with the one developed in San Francisco and some of the anti-malarial drugs that have been used to treat people. There are regulatory barriers in the United States about what information can be communicated in medical journals about effects. Those get even more severe when you move into the EU, when you move into countries in Asia. So I think right now it's an information problem, and the lower the barriers you can get on those, the better. I don't know what the ultimate solution to the global pandemic is, but I think information is the only way we're going to find one.
Jeffrey.
Well, I agree with everything Raymond just said. In addition to that, I think everyone has a right to self-medicate and a right to test. Now, in the United States, we passed this right to try law a couple of years ago, which permits people, many people may not be aware, there's 3 stages of clinical trials that the FDA requires before you can get approved to market your drug. Stage 1 is safety. Stage 2 is efficacy, and stage 3 is comparing it to other drugs. Right now, remdesivir, the drug that has been shown to be very effective and safe in treating COVID, is awaiting stage 3. Why in the world do we have to wait for stage 3 for it to be compared to other drugs, which basically don't exist, when it could be getting out there right now? So the right to try law allows people to, when they're desperate, when they're terminally ill, to try any drug that's past stage 1, which has been shown to be safe. I think we should have a right to test law as well. And I don't think we should limit it to people who are terminally ill and have tried everything else. I think people have a right to try any drug they want and have a right to be available to any test. Now, I'm talking about, an ideal libertarian world. In the real world, I think what we should do is, for example, go back to eliminating the efficacy requirements that the FDA has and many other countries have in place. If a drug is proven to be safe, then let it get out there and let the doctors and the other healthcare practitioners, using their judgment and their knowledge and sharing their knowledge, decide about whether or not a particular drug is efficacious. Already, once the drug is approved by the FDA for marketing, then they really don't care if you use it for what it was approved for or for anything else. They trust your judgment. So then they should trust your judgment for everything. So that's another thing I would add.
Thank you. Ivana, any points from you?
Sure. I don't know about the global pandemic, but certainly for Government of India, three things. One is competition for accreditation, right? India used US FDA and EU standards at this time, so why not forever? So I think that's critical. So as much competition, but if we were to take that the sort of global story, why can't we have public-private competition in accreditation? So if there is safety accreditation, etc. So that's recommendation one. The recommendation two is, at least in our case, we need to quickly move to a way of public finance and private provision for testing and hopefully eventually healthcare as well, because I think the externalities case is strong enough. And number three, let's get rid of some of the essentiality norms and regulatory standards, which I think are false and inefficient in the case of hospitals in particular and healthcare professionals.
Fantastic. Thank you so much. To sum this wonderful panel and its outcomes, to sum this up, we figured out coronavirus is not something not a problem governments have created, but they are very rigid regulatory framework of making it hard to increase hospital capacity, making it hard for doctors to practice, making it harder to bring a drug to the market, making it harder to mass manufacture tests and get tests approved, have worsened the situation. Probably COVID-19 is here to stay for some time. A very quick deregulation of as many regulations in the field of testing, drug development, and provision of healthcare, no matter in which country we are, would help us to mitigate this crisis much better and be more resilient to the next crisis. Thank you so much. For everyone who's listened, also thank you for your wonderful questions. On the YouTube link, we might be able to add the social media handles of our fantastic panelists, so you can stay engaged maybe on Twitter or LinkedIn with our panelists about that issue and other healthcare and public policy topics.
Thank you.
Thank you, everyone.
Thank you, everyone, for joining us today. We look forward to seeing all our participants tomorrow. And that's a sign off from day one of the conference on policy in pandemics. We look forward to seeing you tomorrow.